Hello, my name is Dr. Robin Hubbard, and I am one of the obstetricians and gynecologists at Grand Rapids Women's Health. Welcome to the Ready Set Baby class, where we will talk a lot about what you need to know in the third trimester of pregnancy, for your labor and delivery experience, the hospital course associated with that, and your postpartum. So I have attached to the handout that you received a kind of link with all of the different times and places you can find things on the video, and I'll walk you through as we go. So I'd like to just make sure that we have some reminders covered. So at Spectrum Health, the first thing is, where are you going? Do you know where you're going? We have a packet of information that is available to you that we try to offer you in the third trimester that has a map, and Spectrum Health Butterworth Hospital is where we do all of our deliveries. You're going to enter at the Women's Center or Maternity Admitting entrance, and that is on the corner of Ransom and Crescent. And that's really the back side of the hospital, because most people think of it being on Michigan. So you don't go to the emergency room, but you follow the signs for Women's Center and enter on that back side. OB triage is on the A level, right there by the entrance, and whoever's coming with you can park in that ramp 6 right there. The entrance to the parking ramp is right by the doors for the Women's Center and can come join you. So that's where the hospital is. Later on in the video, we'll have a hospital tour to show you around what the different steps are and places you might experience while you're there to have your baby. So next step would be the pediatrician. Have you chosen your pediatrician? It's a good time to start thinking about that now. We have a list of different pediatrician and family medicine providers throughout the area. And we can give you some good advice if you're interested. Another way to find out is to ask friends in your neighborhood, your community that have children, and see where they like and where they've been happy. So that's a really good thing to put on your agenda for prior to having the baby. Some pediatricians in our community will come to the hospital and see your baby while you're there, and some do not. And if that in that case, then you see the hospital pediatricians. Either one is totally fine. As soon as you're discharged, you'll be released to your doctor that you've chosen. And so I don't think that that is crucial in your determination of which pediatrician to use. Prenatal classes. So there are a variety of classes available. Spectrum Health is offering classes both in person and virtual, and that may change as COVID evolves. And you can access them at spectrumhealth.org and look at parenting classes. It's through the Healthier Communities. There's also private places, both in the community and online, that offer different types of birthing classes, so look into that. I do think many of the options that I've heard really good reviews are breastfeeding. I think the breastfeeding class is really helpful, just to give you pointers and tips on strategies that can help you be successful. We also have a very good program at the hospital where the lactation consultants and the nurses will help you to be as successful as you can. The other classes that I like are the car seat class and the what to expect class that kind of covers several hours or several sessions of meeting, going over a little more detail than we will here in this video about labor and delivery and the actual birth process. And then of course there's other types of birthing classes like Bradley and Lamaze and other breathing classes that you can access. So lots to look at. If you have questions, please talk to your provider. We would be happy to give you some guidance. Okay, so I mentioned that the hospital tour is later in the video. We are not offering tours right now, but there is a video one available for you to peek at coming up. And bags packed. So I think probably by the time you're 35 weeks or 36 weeks, it's a good idea to have your bags packed. And really, the hospital has everything that you need if you just drove off the street and showed up at our door. We have deodorant and toothpaste and beautiful hospital grade underwear that you can wear, which come in really nice right after a delivery. So you really don't need anything, but it's nice to pack things that just make you feel comfortable, your own fluffy slippers, your robe, a nice like Bluetooth speaker, chargers, anything that just makes you feel a little more comfortable. And partners, it's good for you to just think about the things that make you comfortable, your comfy sweats, your thick socks, and even snacks or items that you might want to have to munch on once you're in the hospital. Moms, once you're there, once you're in active labor, we just stick with clear liquids usually for a couple reasons. One is that you can be nauseous and you can even throw up in labor, and so we try to just limit what's in your stomach so you're less uncomfortable. And number two, if there's a reason why you need a more urgent cesarean section, then having a more empty stomach is safer from an anesthesia perspective, so we decrease the risk of aspiration. But partners, you can get food either from the cafeteria or you can order from the menu, or you can bring some food in with you. So those are kind of some great options. Car seat. You need to have a car seat in order to take your baby home with you. Look at all the reviews and figure out. I remember trying to see how I could fit 3 car seats in the back of my sedan back in the day. And there's a lot of regulations and guidelines that change, so it's good just to keep up on that information. And if you're shopping online, make sure that it's a car seat that's had good reviews and meets all the certifications. It's better not to use a hand-me-down or used car seat, certainly not a car seat that's been in a car accident. Those are better to discard just because it could affect its safety. And then I recommend having it checked. A lot of fire stations and car seat testing areas are available in our community, and you can look into that just to make sure that it's in. Interestingly, 70 to 90% of car seats are not installed properly. And that's even for experienced parents that have multiple kids and have been doing it for a long time. So really good just to make sure that you're on target with that. I'd like to talk a little bit about COVID. I'm going to summarize what we currently know. And as you know, I'm recording this now in November of 2021. So we are more than a year and a half into this, and guidelines and recommendations change quite frequently, as do hospital visitor policies. So currently we have 2 adult visitors are allowed in the maternity department at Spectrum Health hospitals, and that means your partner and 1 other person. Currently, that person needs to stay the same, but they can come and go and go get food or run home or go out to the car, for example. And that could change either with higher COVID numbers, or as COVID numbers drop, it might become more open. So double check with Spectrum. The general visitor policy is a little bit different than the maternity and the pediatric hospitals policy. So look into that, or your provider can update you. It's good to keep family members that would like to be there for the delivery just kind of on a wait and see basis, just so we know for sure. It's important just to realize that with COVID that we are doing everything possible at Spectrum Health to keep you as safe as possible. We want you and your baby to be safe and healthy. So we are invoking a lot of precautions at the hospital, and the hospital is still the safest place to have your baby. Early on in COVID, a lot of people were considering doing home births or changing their attitudes, but I definitely recommend the safety of a hospital delivery with an OBGYN provider taking care of you. We have all sorts of infection protocols. We will be wearing masks the whole time that we take care of you. And actually right now, we'll be asking you to wear a mask as well. Moms, when you come into the hospital, they will do a COVID test to screen you. That's the current policy. Sometimes that has changed with your vaccination status. If you are COVID negative and at some point in your labor you feel the need to take off your mask, that will be okay, because the hospital is requiring vaccinations for its staff, and we will be wearing our masks, and so it will be safe for you to do so. Dads or partners, we are asking you to keep your mask on throughout the time that there's a healthcare provider in the room with you. When you're privately in your room together, of course, you can take them off. We just want everybody to be as safe as possible. Good reminders. Make sure that you wash your hands frequently, really well. The hand sanitizers are all over the hospital, and there's soap and water in your rooms. It's also important to try not to touch your face a lot, try not to take your mask on and off a lot. If you do, wash your hands before and after. And if you have any signs of a cold or COVID, which could include a fever, congestion, loss of smell or taste, stomach problems, vomiting or diarrhea, cough, shortness of breath, that you reach out and let us know so that we can quickly get a test. I know a lot of people are confused by, do I have allergies, or do I have a cold, or do I have COVID? And we really don't know until we do a test. So it's good to know. We have a lot of data on how to keep you safe in pregnancy and how to keep your baby safe. COVID can affect pregnancy more severely than women who are not pregnant. So we know that you are at an increased risk of either having more serious infection, becoming hospitalized, requiring ventilation, or even dying. For that reason, we have been studying it as quickly as we can and getting as much information throughout the world on pregnancy and COVID. What we know is pregnant women are a little more likely to develop blood clots when they have COVID and a little higher chance of having preeclampsia as well. We've changed some of our protocols, so we are recommending that you receive a vaccination. If you haven't already, receiving a vaccination at any stage of pregnancy has been shown to be safe and efficacious. It protects you and you pass antibodies to your baby, which is very important and can help the baby in the newborn period of time from developing a COVID infection if they have exposure. I think that there's been a lot of controversy about the vaccine, and we have a lot of information that we can share with you, studies, data on the safety and efficacy. The vaccine does not lead to infertility or miscarriages, and that has been shown in good, robust scientific trials in multiple locations. So I really recommend that you get your COVID your COVID immunizations. If you're due for a booster, it's time to get that, and I do recommend that you get that at the time that it's recommended. Both Pfizer and Moderna boosters are available right now and are recommended. Johnson & Johnson has been approved as well. So if you have further questions, let us know. The other thing is, if you develop COVID when you're pregnant, monoclonal antibodies are part of the recommended treatment for people who have mild or asymptomatic COVID and who are pregnant, because you're considered higher risk. We can make that recommendation and the referral to the different places. One is Spectrum Health that does monoclonal antibodies. Other medications might be aspirin. A low-dose baby aspirin can help reduce the risk of blood clots. Please talk to your provider if you get a diagnosis of COVID so we can navigate these different things and help you be the safest. Even if you think you just have mild symptoms and it's not a big deal, I really want you to reach out to us so that we can make sure that we're addressing all of the concerns that can happen during your pregnancy. If you happen to be positive for COVID at the time that you come in labor and delivery, that's okay. We still deliver your baby. It's still a beautiful experience. We don't take your baby away from you. We just wear more protection to keep ourselves safe, and we have the baby and your partner stay with you in the room the whole time that you're there. There are some recommendations about keeping your baby safe that we will go over with you in terms of how you interact when you're in the room, but breastfeeding is still recommended and bonding with baby is still important. It's just a little harder because you're not supposed to kiss them. That's really tough. So still trying to social distance, wear your mask when you're out is important, even though not everybody's doing that at this time. A couple more COVID thoughts. A lot of people have talked to me about unvaccinated family and friends and how they would like to address that either during their pregnancy or in the newborn period of time. I do think that there's a higher risk of unvaccinated people carrying COVID or being sick with COVID, and so it's important to consider that when you're making decisions about how you have interactions with your newborn. The other things that are just as important include influenza and RSV, or respiratory syncytial virus. That currently, we're in the fall, and that is pretty robust right now. And so babies can get sick from all of these things, and we have recommendations to help. we do recommend that you get your influenza shot, your vaccination for flu, and that all the people that are going to be around you, your partner, siblings, grandparents, babysitters, receive their vaccinations as well to help keep the baby safe. And we offer you the pertussis or whooping cough booster as a part of the Tdap series during the pregnancy so that the baby can get those antibodies and reduce that risk. So there's a whole constellation of things that we have addressed to try to keep you safe in pregnancy. One of the other things that I wanted to mention was babies. Babies don't seem to be getting COVID infections very often. However, there is reports and risk of transmission from infected moms to babies, and babies have been born COVID positive, which of course would be quite concerning. The biggest thing that we have seen is moms who get very sick from COVID require intensive care unit management and ventilation, and then in order to help save their lives, because of their severe illness, we've had to deliver them early. And so the greatest risk that I've seen for babies, and one of the most important, is prematurity. Babies have been born as early as 23, 26, 32 weeks, where babies have been born early and required hospitalization in the neonatal care unit. And although we have a wonderful neonatal care unit, that is not how we're hoping to have your baby. So I just wanted to address questions that people have had about that as well. Okay, we're going to talk a little bit about normal pregnancy. So the third trimester of pregnancy is starting at 28 weeks, continues on until you have the baby. Your due date is 40 weeks. Now that's from the first day of your last period, and that is just a guess. So only 5% of people deliver on their actual due date. About 40% of people go past their due date, so keep that in the back of your mind that you might actually go past. And the rest of people go before. So the birth of your baby might seem like an anxiety-provoking time. Your body starts to really grow, and you start getting a lot heavier and more uncomfortable. Pelvic floor, your pubic bone, your hips start to get a lot more uncomfortable. It's harder to get in and out of bed. It's harder to sleep. And so there's a lot of things that make this time physically a little more strenuous, but more exciting and a little more anxiety provoking as you get closer to having your baby. So it's really important that you just continue to take good care of yourself. And I know in a stressful time like this, when we're homebound, it's easy to fall into bad habits like Netflix and cookies, but that's okay to do that. But make sure that you're still trying to exercise however you can do that. A pregnancy yoga class in front of your couch. Get out on a nice day like today and take a walk. Drink lots of water. Eat good, balanced food, lots of greens, lots of protein, so that you're really taking care of yourself. Try to limit your caffeine, limit your alcohol. Please don't drink or start bad habits just because you're anxious. If you're struggling emotionally or with any of those issues, please reach out to us. We are all there to help. And certainly there's a lot of increased anxiety during this time. Okay, let's talk a little bit about office visits. So at Grand Rapids Women's Health, we are seeing you for your OB care as we normally would, typically every 4 weeks at the beginning of pregnancy, and as you move into the third trimester, every 2 weeks, and then at 36 weeks starting weekly. Those visits are being scheduled in person. We can do virtual visits in a limited fashion if you happen to be ill or COVID positive and not able to come into the office. We can see you if we need to if you're COVID positive, but we try to limit exposure to our other patients and to our staff if at all possible. So please reach out and let us know. I just want to talk through a little bit. We currently have a one visitor policy that may change, but right now we're asking for one visitor. Infants, of course, are allowed, our children that are nursing, and that's for reduction of volume of people in the waiting room, and that could change as we go on. A couple other things. It's important, I think, to do in-person OB visits. At the beginning of COVID, we tried to do as many virtual as possible, but being able to get your hands on your belly and listen to the fetal heart tones, measure your fundal height, which is the distance from the top of your pubic bone to the top of your uterus, check the urine for protein and sugar, check your weight, check your blood pressure. All those things are really important to good prenatal care. And so we are recommending that you come in for your regularly scheduled OB visits, ultrasounds, and tests as scheduled. We can do everything that we normally would do. What to expect at a visit. So when you come in for your routine visits, you're gonna, as we get closer, we're gonna, like I said, offer you your Tdap vaccination, usually between 27 and 35 weeks of pregnancy. We do a group B strep culture, and that is just a little swab that goes in the outer third of the vagina at 36 weeks, and that is to screen for a bacteria called group B strep, kind of like strep throat, but a different type. And it just lives in the vagina of women normally. About 20 to 25% of us carry that and don't even know it. But newborns can get sick as they come through the birth canal and pick that up. So in labor, we treat you with antibiotics given through the IV at the time to reduce that risk of exposure. So it's not a big deal if you're positive. We just identify those that are and we treat you in labor. You don't have to stay hooked up to the IV if you are not asking for pain medicine or requiring it. So that's really good. What else? We might be able to, well, we'll certainly talk about your birth preferences and what to expect at the hospital and things about labor. We can check your cervix to see if you're dilated at all. Make sure that we're doing appropriate testing. If you have a higher risk, like hypertension or high blood pressure, diabetes, some kind of an issue with your baby, a growth problem perhaps, or some type of anomaly that we've identified, then we might do more frequent ultrasounds. We can also do non-stress tests, which are examinations where you just sit in the lazy boy chair with the monitor straps on, one that records the fetal heart tracing and one that records contractions. This actually is a really great test to show us how well the baby's doing inside. And we expect to see 2 accelerations in a 20-minute period, where the heartbeat goes up for at least 15 beats a minute, and that shows us that the baby's doing well and getting good blood flow, and actually that test corresponds to a decreased risk of stillbirth. So we may offer those tests if you have any high risk issues, and you can talk to your provider more about that. Discomforts during the 3rd trimester. So lots of things become more common. We talked about that a little bit. We talked about difficult sleeping. Backache, very common. So there are back stretches. I know there's a sheet that you got in the blue bag at the very beginning of your pregnancy that goes over some of the back exercises. Again, those prenatal yoga classes that you can find on YouTube are really helpful. Try to get some stretching done. Don't just sit on the couch all day, even though we're stuck at home. Constipation is more common, and you can do a good job with your fiber in your diet. Eat some prunes. Drink your coffee, decaf, but you can also use Miralax regularly. You can use stool softeners, and you can add a fiber supplement like Benefiber or Metamucil. Those things are absolutely safe in pregnancy, and you can use them on a regular basis. This is a problem that's super common for pregnant women. Heartburn is also common, and so it is a normal thing. Your stomach empties 4 times more slowly in pregnancy, so it takes like 8 hours for the food that you eat to empty out of your stomach, whereas when you're not pregnant, it takes about 2 hours. So because of that, it can just sit there and it wants to come back up, especially when we lay down at night to go to bed. So Tums are fine. You can take Tums. They're also a good source of calcium, which is important. But if that doesn't work, Pepcid, Prilosec are fine for you to take as well. If that doesn't work, go ahead and talk with your doctor. You can take those every day. Hemorrhoids, something that people don't like to talk about, but it's not an unusual thing with pregnancy. You can get witch hazel pads under the trade name Tux. You can use over-the-counter creams. The most important thing is to try to avoid constipation. If you do struggle with hemorrhoids and you're not finding improvement with the over-the-counter creams, talk to your doctor. There's some prescription things that we can do to help you. And then having the baby is the best thing. So once you deliver, hopefully they will get better. Leg cramps are also really common. So you might get some leg cramps that you haven't felt since you were maybe like high school athlete or something. Leg cramps in pregnancy are really common. A couple things to think about. Are you getting enough calcium in your diet? Make sure you're drinking milk or some kind of a calcium source. Those Tums might be a good idea. You can add some magnesium, maybe a little bit, 500 milligrams a day. Potassium, if you like bananas, have a banana every day. That's an easy way to do it. Make sure you're drinking plenty of water. And then you can gently stretch your calves. You don't want to aggressively stretch them because, you'll get a calf cramp right away. They might not go away, but that's something to think about that might be able to reduce the risk of calf cramps. Nasal congestion or nosebleeds, another weird but very common side effect of pregnancy. So you just feel stuffy all the time, like you've got this mucosal swelling that makes you feel stuffy, and more frequent nosebleeds because your blood vessels are more dilated. That is totally normal. Tuck your nose up, put some pressure on there. If you have a nosebleed that doesn't stop, then you might need to go to a med center for that, but try to prevent it because we don't really want you going out and interacting with the public right now with the COVID situation. Varicose veins are also really common. Support hose might be helpful. You can get those usually through a durable healthcare place. You can order them online through a pharmacy, and that might be really helpful. You could talk with your doctor about that. And then just swelling. It's normal to get some swelling down by your ankles, sometimes in your hands. Rings might be fitting a little more tightly. I do think it's a good idea to take off your wedding rings or whatever rings you like to wear before you go to bed, because it might you might swell up a little bit and you don't want to get them stuck. A little bit of swelling is normal. Again, reduce the salt in your diet and drink lots of water. If it's getting really bad, let us know at your visit and we can talk about other strategies. And that's one of the reasons why we see you in the office, to keep checking for your blood pressure and other symptoms. In its worst case, swelling can be a sign of preeclampsia, but by far the majority of people with swelling in pregnancy just have swelling in pregnancy. And I hope that our weather keeps getting nicer and nicer, and if we get a nice warm hot day and you go out for a walk, you might get some swelling, and that's really normal. Stress incontinence. So stress incontinence is one of those things where you can leak urine just with a cough or a sneeze or a lift of a baby or a bag of groceries, and that is not that unusual with a baby. It doesn't mean that you are going to have it happen after you deliver, although it could. Some things to think about. The baby is sitting right there on your bladder, and especially in the third trimester, when the baby is more likely to flip over and be head down, where the head is pushing right there on the bladder next to the pubic bone, there can be so much pressure that your poor little sphincter just can't control it and you might leak a little bit. It is okay. Think about doing your Kegel exercises where you tighten those muscles to try to increase the strength of your sphincter and help control that a little bit. Don't worry. If you need to go to the bathroom more frequently, go. I know a lot of pregnant women feel like that's all they do is go to the bathroom, and then when they go, it's like a teeny little amount. Totally fine. It might be an early sign of urine infection. Probably not just if you leak, but if you have any symptoms that are changing, burning, urgency, frequency, let us know so that we can check for infection. When you come to the office and we're dipping your urine, we're looking for protein, which is a sign of preeclampsia, and glucose, which is a sign of diabetes. We're not checking for infection routinely, so if you have any indication that you might have an infection, let us know. That'd be important to know. If stress incontinence doesn't get better after you deliver your baby within about 6 weeks, please let your doctor know. There's stuff that we can do to help you. That's pretty straightforward. I'd like to address travel. So early on in this video, when I recorded it, we were all in quarantine, so I need to update that. Travel in pregnancy, just some basics. Driving around town, please wear your seatbelt. Seatbelt is still the safest, and as you get bigger, it feels a little awkward, but you put the shoulder strap above your belly and you put the lap belt below across your hip bones, and it's really important that you wear your seatbelt. If you're in a motor vehicle accident, the most risk is to you having an injury, and the seatbelt will help prevent you from being thrown from the car or seriously hitting the steering wheel, etc. So it is really important that you wear your seatbelt. If you get uncomfortable driving or lightheaded at the end, sometimes that awkward position leaning back isn't great while you're pregnant. Just really pay attention to that so that you can be as safe as possible. Traveling out of town. I think that it's okay to go for up to about an hour and a half away at the late stages of pregnancy. So I'm going to work backwards. Between 35 and 36 weeks, you're getting close enough that you could go into labor. Term is considered 37 to 42 weeks. And so if you do go into labor, it would be good to be within about an hour and a half of Grand Rapids. Some people live that far away. And to have access to somebody that can drive you in case you do go into labor, because you can be uncomfortable and not able to drive. If you're thinking about traveling farther distances, I recommend doing that earlier in pregnancy, earlier than 35 weeks. And you can have long car rides, but it's important to think about that and stop every 2 to 3 hours, walk around quite a bit, just to reduce the risk of blood clots. You're probably going to have to go to the bathroom anyway, because that's just how pregnancy works, but that's one important thing. Some people will get some support hose and wear those if they're in a prolonged car ride, which works all the way up until you get to Florida and it's super hot, and then you decide you want to take them off. But that's not a bad idea. Plane travel is definitely okay in pregnancy. I recommend up to about 34 weeks. Some people have to travel beyond that for work, but that's a good place to think about stopping. Again, safe. You just want to stay hydrated and reduce the risk of blood clots by getting up and walking around a little bit, maybe wearing support hose. And travel is good. I do want to introduce the idea of infection and COVID in the concept of travel. If you're traveling to an area that has a lot of COVID, it's really important to give that a thought and make sure that you're reducing your exposure. The other thing to think about is the Zika virus. Many of the Caribbean islands, South and Central America have had Zika virus infections, which in rare cases has led to microcephaly, or small heads in babies, if it has been transmitted. This risk seems to be reduced in the last couple of years, but it is still out there. I recommend that you check the CDC website for more information if you're thinking about going someplace more exotic. Kick counts. So kick counts in the third trimester are something that you can do just to follow your baby. So I'm sure that you can feel the baby kicking and punching and moving. A lot of people feel like the peak movement is between 30 and 31 weeks. So baby neurologically is developed enough that they can be pretty wild in there. Sometimes you can just see your belly moving and shaking. After that, babies feel like they might slow down a little bit. And I never want your baby to stop moving, but they might get just a little more squirmy because they get big enough that they're so crowded in there that they can't quite do the punching and kicking that they once did. So kick counts are a way for you to just touch base. Keep in mind that babies can sleep for about 90 minutes at a time, and so napping is totally fine. Within that time frame, I'm not worried. But if you've got a half a day period where you think, gosh, my baby just is not doing its normal thing. Usually, every morning, baby's really active right about now, and it's not doing that, then absolutely touch base and try to do a kick count. What I recommend is that you eat or drink something that might stimulate the baby. Ice water, maybe something with a little sugar or a little caffeine. Lie on your left side and focus just on the baby. This is not a time for multitasking. Every movement, a roll, a punch, a kick is a movement. So you should get 5 movements within an hour. Usually, if the baby is moving, you can do that in 5 minutes. And then you know everything's fine. If you don't panic, but please feel free to call us and let us know that you're having some decreased movement, and we can easily increase the way that we're surveying the baby, have you come in for a non-stress test to make sure that everything's okay. I never really want the baby to stop moving. Having said that, sometimes when you're really busy at work and you're distracted, you're not feeling the baby move, that's okay. On your break or right after work, touch base and connect so that you know that you have assessed what's going on with the baby. And again, never be afraid to call us if you have any concerns or questions. Okay, so general pregnancy warning signs. Please call the office if you notice any of the following things. So if you notice vaginal bleeding that requires you to wear a pad. So a little tiny bit of spotting is okay, especially if that follows intercourse, an unusual episode of lifting, something like that. I'm not super worried. But if you have heavier bleeding that requires you to wear a pad, please let us know so that we can evaluate what's going on. If you have a fever above 100.4, especially right now, that would be a sign of infection or COVID, a new cough, a new shortness of breath. If you experience pain or burning with urination, which can be a sign of urinary tract infection, and if you have sudden swelling in your face, hands, or feet. Now, mild swelling is okay, but sudden dramatic swelling could be a sign of preeclampsia, and we would want you to let us know. If you have problems with your vision, this is usually spots or flashing lights. So if you're seeing stars or flashing lights, not just floaters, please call and let us know. Or severe headaches that won't go away with Tylenol, please call. Again, those are symptoms of preeclampsia, and we would want to know. One of the reasons why we have you come in and check your blood pressure and dip your urine each time that you're in our office. Signs of preterm labor. So preterm labor is contractions leading to cervical change before 37 weeks of labor. Term is considered 37 to 42 weeks of labor, although we really like babies to be born at 39 weeks to 41 weeks. That seems to be the very best, most healthy time for babies. 37 is considered term. So if you feel like you're having contractions before then we want to know. How do you know? Because some people start having contractions or Braxton Hicks contractions as early as 20 weeks. So at 20 weeks you might notice a little tightening or squeezing or pressure where you feel like your uterus is getting a little bit hard, and that might be really called a Braxton Hicks. But if you notice regular or frequent contractions that are occurring, then we want you to call us. What I tell people is if you're having tightness that is occurring across your whole belly, that's happening 6 times in an hour or more, that doesn't go away after you lay down and put your feet up and drink a big glass of water, then call us. So the first thing I'm going to do if you call me is tell you to lay down and drink water and call me back in an hour. So try that first. And a lot of times it's just that. You overdid, you got kind of dehydrated, you were super busy at work, you were busy with the kids. But if that doesn't work, please call. So use the 6 an hour for contractions. If you don't know what to feel in your belly, I like this model somebody told me a long time ago. A soft uterus usually feels like this, a mild contraction usually feels like this, and a hard contraction feels like this. So if your uterus is really tight, like in labor, your whole belly is going to get so tight that it feels like this. Hard to imagine right now, but occasionally when the baby's moving around, you can feel the head or the butt, and you almost get that sensation. Sometimes it's even hard to tell the difference between what's the baby and what's a tightness. And so let me know. Some of the things that can go along with preterm labor, aside from contractions, might be abdominal cramping, kind of like menstrual cramps, and diarrhea, sudden severe abdominal pain, regular contractions, or if your water breaks. And sometimes that's really obvious. You hear a pop and there's a gush of water everywhere, and sometimes it's not so obvious, where your underwear are wet and you think, oh my gosh, did I just pee my pants? I don't know, but I changed my underwear and they were wet again, and it doesn't smell like urine, and I'm not really sure. If there's a question about that, please call. Even if you're not having contractions, sometimes your water could break and we wouldn't know. So those are the preterm things that we would be concerned about and want you to call our office anytime, day or night. There's always one of the doctors on call ready to answer your questions. So, common normal signs of pre-labor. So what might happen as you get closer after 37 weeks? You might notice a little bit more contractions, lightening, release of your mucus plug. So lightening is just when the baby drops down lower and you feel way more pressure down on your pubic bone and on your bladder, and maybe even a little bit of relief from your diaphragm. You feel like you can breathe a little easier, maybe more room where your stomach is, but a lot more pressure down lower, and that can be the baby dropping. I swear there are people out in the community that think that they can tell every single pregnant woman and whether the baby's dropped, and I've been doing this for 23 years and I still can't tell. So I don't know, some people feel like they need to know if their baby's dropped, and you might not ever know until the baby comes out. Release of the mucus plug. Mucus plug may come. It is it's like very thick, sticky mucus. There might be a hint of blood in it. It might be a sign of labor, it might not be, and you don't have to call us for that. It kind of looks like you blew your nose in your pants. I know that sounds gross, but that's kind of what it looks like. So that is just something that may happen. There's more to come, like a little one can come out now and more can follow a week from now. Unless there's contractions or your water breaks, you don't have to call to let us know about that. Other signs, you might feel like you're nesting, like cleaning under the refrigerator, cleaning out the lint trap on your dryer. We're probably all doing that right now, right? We've been homebound for weeks. You might notice a little bit of weight loss, increased backaches, diarrhea, so those things can go along with labor, but we're really, really looking for the contractions and the breaking of the water. Although only 10 to 15% of the time does your water break first. So the contractions is the big one. So how do you know if the contractions are really, really labor contractions? So there's a little graph on the slide that talks about Braxton Hicks contractions, where there's a segment of the uterus, just a part of the uterus that contracts, a little piece where it kind of gets hard. This is what's been going on since maybe as early as 20 weeks, where a little part of the uterus gets tight. It doesn't really cause back pain. It's not the whole uterus. There's not a rhythmic contract pattern to it usually, and that doesn't change your cervix. They just come and go. True labor contractions will wash over the whole uterus. Often they'll start in the back, they'll sweep over the whole front, the whole thing will get tight, and they come and go in a very rhythmic pattern. And so what we're looking for is that to occur every 5 minutes or closer, from the beginning of one to the beginning of the next one, and to last at least a minute, usually to the point of being painful enough that you really can't talk with it. I can tell when I talk to people on the phone, when they call me, when they say that they think they're in labor, if you're like, oh my gosh, I'm having contractions, they're every 5 minutes, and I'm so excited because I've been really excited to have my baby, and I think this is it, and I'm having one right now, I'm like, oh yeah, you need to stay home a little bit longer. But if you're like, oh my gosh, I'm having one, honey, you need to take the phone because I'm getting one, I think, oh yeah, you need to go to the hospital. So I can tell just by the tone in your voice that the intensity of contractions is there. And then once they're 5 minutes apart and that level of intensity, it's good to stay home if it's your first baby for about an hour at that level. Then give us a call. Call us at the main number for Grand Rapids Women's Health, 588-1200. Talk to the doctor on call or the nurses in triage if it's during the office hours. And if it's time for you to go to the hospital, we'll call the hospital for you and they'll know that you're going to come. So that's kind of how we like to do it, and that's what we're looking for with contractions.
Hi, I'm Erin Hoekstra, one of the OBs at Grand Rapids Women's Health. I am here to give you a hospital tour since we cannot have people coming into the hospital for the tour right now. So I am standing outside of the Women's Center entrance. This is where you want to come in when you are in labor, and hopefully you will have called our office already to tell us that you're coming in, talk to the doctor on call. I am at the corner of Ransom and Crescent Street, so we are back around the side of the hospital from the ER. And this is where we want you to come in. We have a separate entrance from the ER. We have a separate area where we evaluate patients for labor and delivery, and all of our obstetric patients over 20 weeks come in at this area. So next I'm going to take you into the OB triage area where patients are going to be evaluated. So this is the area where you're going to enter into maternity admitting OB triage. In this area of the hospital, we have RNs that staff this area, we have nurse midwives that are here, and we have nurse practitioners. So you will be evaluated by a nurse and possibly a nurse midwife or a nurse practitioner depending on what's going on with you. Come with me and I'll show you one of the rooms in here. All right, so here I am in OB triage. When you come in, you will check in on our desk here. Megan is our staff member that is staffing the desk right now, our secretary. And once you've checked in here, you will come into one of these rooms where you will be evaluated. This is what one of our triage beds looks like. We have monitors in these rooms. Your baby will be monitored and your contractions will be monitored. We evaluate patients here for labor, water breaking, problems with your baby or pain that you have during pregnancy, and many other issues that patients are evaluated for in this area. If it is determined that you are going to be admitted to the hospital, your doctor will be informed and be in touch with the nurses here, and then we will bring you upstairs to a labor room. So next I will show you that area of the hospital. So here we are on labor and delivery. I'm going to show you a standard labor room and what things look like in here. Follow me. So here we have our standard labor bed. It looks pretty similar to the bed that you would have had downstairs in triage too. What we like about these beds is when it comes time to deliver your baby, we can put up stirrups to put your legs up. We can take the end of the bed off so that the doctor can be there to deliver your baby. You will probably just be in the regular bed most of the time. If you come in and you want to walk around, we let you walk around in the hallways. We have birthing balls that are available. We have tubs in all of the rooms that you can use. And as long as your baby is doing fine and there's no contraindication, you should be able to do all of those things. Once you get to this room, you will have a labor and delivery nurse that is dedicated to you. You will have a monitor on for your baby. You will have a monitor on for contractions. If you are doing great and you want to move around a bit, you do not necessarily have to be monitored the whole time as long as everything is going well. You will be met here by your labor and delivery nurse, and then you will have an anesthesia nurse that comes and talks to you. They will talk to you about the epidural. Even if you think you don't want an epidural, just talk with that anesthesia nurse. If something urgent comes up or if you decide to get an epidural, they will be available to you. The other pain medications that are available is that you can get some IV Stadol, which is a narcotic. And that is a great thing to use before you would get the epidural. Once you are here, we monitor you to see the progress of labor. Some patients end up needing Pitocin to help things along. Some patients have to have their water broken. Sometimes we place internal monitors. If you have questions about those things, I would encourage you to talk to your doctor about those type of things. Your doctor may be in here some parts of your labor, but probably not the whole time. So your labor and delivery nurse is going to be your best friend here and take really great care of you. And all the staff here is here to try to make your labor experience the best that it possibly can be. I will show you the bathroom here just so you know what it looks like. It's a pretty standard hospital bathroom. So we have a pretty good sized tub that you can use in here, and as I said, as long as your labor is going fine and your doctor approves it, you should be able to use that for a good pain control technique. These are the same monitors that we have downstairs, so that's where we monitor your contractions and that's where we monitor your baby. If you have to have a C-section, we have operating rooms right here on this floor that you would be taken to, and we have staff available all the time that are available to do a C-section. If you have a vaginal birth, the vaginal birth will take place in this room, and then you usually stay on labor and delivery for at least 2 hours after a birth, vaginal or C-section, and then you're gonna move upstairs to a postpartum room. So I will bring you guys upstairs next to a postpartum room so that you can see what that looks like. So I'm here on 8 Center, which is one of our mother-baby units. We have 3 floors that patients come to for the most part postpartum, 6, 7, and 8 Center. So all of this is in that center tower where you would have come in initially. 4 Center is another unit that is for obstetric patients. That is mostly for patients that are here preterm or perhaps patients that had other complications that they've been in the hospital for a longer period of time. Now let me show you one of our postpartum rooms. You can follow me down the hall here. This is one of our standard postpartum rooms up on 8 Center. You will have your own private room. You will have a nurse that takes care of you here. There are nursing assistants that work up here as well. They help with newborn care. They help with circumcisions. Most patients on this floor will stay for either 1 or 2 nights after a vaginal birth and 2 or 3 nights after a C-section. So this is a pretty normal room. The cafeteria brings you food here. It's actually pretty good cafeteria now. You can see over here, there's a breast pump here, so they do provide hospital-grade breast pumps, and they will provide the supplies if you need to use that while you're here. So you do not need to bring any of that with you. We have just a normal-looking bathroom here. There's a nice shower here. They're gonna provide you with pads and ice packs and ice diapers and whatever you might need after your delivery. While you are here, your doctor will also come by and take care of you. We round on our patients every day that you are here. If you have a baby boy and you would like him to be circumcised, that is our team that does that for you, and that is usually done either the first day after delivery or definitely before you would go home. I hope that you liked this hospital tour and that you feel a little bit more confident about what's going to happen when you come to the hospital. We feel really confident that our hospital is a safe place for you to have your baby, and we are all here to take really good care of you. I hope that you guys all have a really good day.
Okay, hospital care. Let's say it is time to go to the hospital, and let's talk a little bit about what happens once you arrive at the hospital. I mentioned how you get there. You're going to go to the maternity admitting or women's center entrance where Ransom and COVID and Crescent meet, and go to OB triage. OB triage is kind of like the OB emergency room, but it's also the place where we assess women in labor. And if you think that you're having those contractions every 5 minutes, painful, and stay that way for an hour or if your water has broken where you're leaking fluid and whether you're having contractions or not, I recommend that you go in. We prefer that you call us first, the doctors at Grand Rapids Women's Health, which you can. Reach us by area code 616-588-1200. That's our main line, and during the office hours, you hit the OB triage, the nurse button, and that will get our OB triage nurses on the phone quickly to let us know what's going on. After hours, it goes to the answering service and they page us directly and we call you back. Once we know that you're in labor, we've decided together what to do. Call us if you have any concerns or questions. Somebody's on 24/7. We call the hospital and let them know that you're coming so that they can pull your chart, which we've already forwarded, and be ready for you. Once you get there, one of the nurse midwives at OB Triage will assess you, and a nurse will take care of you and will put you on the monitor and watch the heart tones and make sure that everything is looking good and see if you're in labor. If you are, which basically is regular contractions with a change in your cervix or your water broken, then you'll get admitted. Once you get admitted to the hospital, you go up to the second or the third floor. We have labor and delivery rooms, all private, in those areas where you will be for your labor, your delivery, and your recovery. Usually about 2 hours after delivery, you stay in that room, and then you move up to one of the postpartum floors, which are found on 6, 7, and 8 of the center tower. The fourth floor is reserved for antepartum patients, and those are patients who are still pregnant usually, but have some issue that requires them to be hospitalized, like preterm labor or early ruptured membranes or an issue with the baby that requires us to watch you more closely. And those patients are taken care of on the fourth floor. So once you're in labor and delivery, you get monitors placed, kind of like I described for the non-stress test. And basically the two monitors that we use, one shows contractions and one shows fetal heart tones. Most of the time, this can be done using external monitors, which are placed with belts around your belly, just to show us the change of shape of your belly with a contraction and the ultrasound recording of the baby's heartbeat. And this just shows up on a monitor. You can do this with intermittent monitoring if you're low risk, where we use, kind of like in the office, the Doppler to hear the heartbeat, or with the monitor belts on that are attached with a cord, or we have telemetry. The telemetry ones are nice if you're going to be in the whirlpool, for example, moving around the room, or even walking in the halls. And so you have a lot of options for monitoring. We have a policy for monitoring where we do record the baby's heartbeat either continuously or intermittently, and just talk with your provider more about that. But that helps us know that your baby is safe during labor so that we can respond if we need to for any stress that the baby might go through while in labor. Once the monitors are on, then we record your blood pressure periodically. You have the ability to move around the room. There's a private bathroom, there's whirlpool tubs, and we have everything you need. There are birthing balls and peanut balls and squat bars and rocking chairs and all the things that you might need to help you in your process of labor. And it's good to be familiar with all those things, but you may not even know what you want. I mean, I found in my labor that I was pretty fickle. About every 5 minutes I wanted to do something different, and that's maybe the case for you too. So just know what your options are. The labor and delivery nurses are amazing. They really will help you offer options and choices, help you with ideas on things to try to work through your labor. And you just kind of make yourself at home there, and you'll have a labor and delivery nurse that will take care of you, and there will be a doctor at Grand Rapids Women's Health that takes care of you. Usually our doctors we follow our own patients as much as we can. So if it's during the work day, we often will make you our priority, and as you are closer to delivery, we leave our patients at the office, and you may have been rescheduled for that, so thank you, to come and take care of you and be there for your delivery. And nights and weekends, we have a call schedule where we share responsibilities of taking care of other patients, and that is from 5 p.m. to 7 a.m. on weekdays and on the weekends. And so you could have a different provider, maybe me, and we will take great care of you. Our partners are wonderful, and we are all really uniform in our thoughts and focus on making sure that you have a really positive experience and that mom and baby are as safe and healthy as possible. Once you are in the hospital, you'll be checked periodically. Your cervix will be examined to see what kind of progress you're making. And at the beginning, you're going to dilate kind of slowly. You kind of dilate between, on average, 1 centimeter an hour, and it can be slower and it can be faster, but that's about an average. And once you're 10 centimeters dilated, that's when you're going to push. Pushing can last anywhere from a few minutes to several hours, sometimes 3 hours. I've done a few even longer than that. And we are usually there with you that whole time to help you deliver your baby and to recover afterwards. Once the baby's born, then we deliver the placenta and check and make sure you're not having too much bleeding. It is recommended that we give Pitocin after deliveries, even if you don't need Pitocin beforehand. Pitocin is giving to help the uterus contract, and it has been shown in large controlled studies that it will reduce the risk of hemorrhage or excessive bleeding that could be dangerous to your safety or require blood transfusion. So we do give Pitocin through the IV or as an injection after the delivery to help your uterus contract. Once the placenta separates, you have blood vessels that have been passing blood at about 600 cc's or mLs per minute. That's a huge amount of blood, and we want those vessels to close off immediately so that your bleeding decreases, and that's the rationale for that. We are very focused on making your birth experience a really positive one. So we are doing delayed cord clamping. Spectrum's policy is 1 minute for delayed cord clamping. That's based on good data showing that if we wait for a minute before we clamp and cut the umbilical cord to the baby is allowed to get a few more red blood cells, and that babies do a little bit better with that. So that's our policy. Unless the baby is in need of resuscitation right off the bat, we will wait. And then the baby will go to skin, right on your chest. If there's a reason why the neonatal team comes to the room for your delivery, which there's a pretty long list. If there's a meconium, if the baby has had a bowel movement in the uterus, if we do forceps or a vacuum delivery, if the heart tones are looking a little bit concerning at the time of delivery, if your baby has an issue with growth, or if you have diabetes or high blood pressure, we might ask the neonatal team to be there. We are blessed to have DeVos Children's Hospital attached to Spectrum Health and a part of our institution, and the neonatal unit there is second to none. They are amazing, and their teams will come to be there for your delivery. They're just there if your baby needs something. So most of the time the baby will stay with you, the neonatal nurse will have a conversation, and within 5 minutes they leave. But if your baby needs any additional help or resuscitation, or if there is an issue with your pregnancy or the baby needs help, they're there to give excellent care. And that's always great peace of mind. Let's talk about some of the other options for delivery. So I mentioned forceps and vacuum. Sometimes when you're completely dilated and you are pushing to have your baby, you need to deliver more quickly. There's a couple of reasons. One is that you're just exhausted, which sometimes happens. Labor can be really long. You may not have gotten great sleep prior to, and then some women push for upwards of 3 hours. That's not the average, but it can happen. If that happens, sometimes we can help you. Or if the baby has some sign of stress that we think the baby needs to be delivered sooner than you would be able to do it on your own, we might offer you a forcep or vacuum. This is a conversation that you'll have with your healthcare provider at the time, and we'll go over the risks and benefits and reasons why we might be offering it. You can always say no and ask for a cesarean section, which is an alternative. I like to offer people in the right situation the option of having what we call an operative vaginal delivery. Forceps are spoon-like metal instruments that are shaped to fit the bones of your pelvis, the curve of the bones of your pelvis, and also the shape of the baby's head. They're placed through the vagina, and we make sure that your bladder is empty and you have adequate pain medicine. And then when you push, we gently pull to guide the baby's head under the pubic bone and out. And sometimes it's amazing how much faster you can deliver when that happens. Vacuum is a suction cup, little suction cup that's applied to the top of the baby's head. Same idea, you push, we pull. And there are, of course, some small risks associated with that procedure, just like any, and we will go over those with you. But it's good to know that that's an option out there. Let's talk a little bit about cesarean section. So we do know that about 23% nationally and at Spectrum Health of babies are born by cesarean section. That number has been higher. We're working on reducing it, but doing it safely. So it's important to kind of think about that as an option, even if you're low risk. And some people are like, I didn't even read that chapter of the book. I think it's good. Read that chapter of the book or think about it. Our goal is to try to have the baby born by vaginal birth, but there are definitely several reasons why a cesarean section might be safer for you and your baby. Sometimes that's determined ahead of time. For example, the baby is in an awkward position, either breech or transverse, and maybe we tried to flip the baby to go head down, but it wouldn't work. Or there's a reason why you aren't healthy enough to have a vaginal birth. There are some women with certain heart defects or medical conditions that make that a little more dangerous. People that have had a history of pelvic fractures sometimes. And then sometimes it happens just out of labor. For example, the baby's heartbeat is very concerning and you're not close to delivery, and we recommend that we do a C-section for the baby's safety. Or you're not making progress, and despite all of our best efforts, which we really try, all the position changes, making sure your contractions are adequate, adding Pitocin, which is a medical way to help create contractions. It's the exact same chemical that your brain produces, oxytocin, and is given to try to increase the strength of contractions if they're not strong enough. But sometimes you just get stuck and not able to deliver the baby vaginally. Sometimes it's because the baby's too big or in a funny position. Definitely can't predict that very well. And so C-section can be done. I've had one vaginal delivery and one C-section, so I can speak about both experiences. The C-section is done in cesarean section rooms that are found on our labor and delivery floors. We have 3 brand new OB cesarean section delivery suites, which is great. Occasionally we go over to the main hospital if our patients are a little bit higher risk, just down the hall to the main operating rooms. We have a little bit different access there to specialists or super high risk care if we need to. But the OB ORs are designed just for deliveries, and we do cesarean sections throughout the day. You can have one partner with you, and the baby stays in the room with you. If everything's going well, the neonatal team can come to the room if they need to. Really, we can still do delayed cord clamping. If you're feeling up to it, you can have skin-to-skin contact, so that is really great. A C-section is typically done with a low transverse incision. We call this a bikini cut. It's like 2 fingers above the pubic bone. Sometimes when women are a little heavier, we modify that, or if it's a true emergency, we will change that, but that's a typical way. And it takes about 5 minutes to get the baby out and about a half hour to close all the different layers. We close the layers with stitches that dissolve and are absorbed over time, and then we close your skin with a buried row of stitches and some glue. This glue is waterproof. It's like surgical super glue. Stays on for a couple of weeks to help keep your incision protected, decrease the risk of infection, and you don't have to worry about a dressing or having staples removed. You can shower right away, which is really nice. You will have a catheter in your bladder if you have a C-section, and that comes out at 12 to 24 hours. We do lots of things to help keep you safe, like added IV antibiotics to reduce the risk of infection, SCDs, which are sequential compression devices. They help squeeze your legs and give you little massages to help reduce the risk of blood clots. And so everything we do is always with a mind for safety and a positive experience on your part. Oh, after a cesarean section, you go to the recovery room where you will stay for a couple of hours. Unless baby needs to go to the nursery for some reason, the baby will be with you that whole time. You can have the baby right on your chest. You can breastfeed at that place. And then you'll go up to your postpartum room just like if you had a vaginal delivery. Let's talk a little bit about pain management options in labor. So there are a lot of things that you can try. Early in labor, there are a lot of recommendations for moving around, practicing breathing, maybe trying the shower or the whirlpool tub. We don't do water births, but you can labor a lot in the whirlpool tub or in the shower, and sometimes it feels really good to have that hot water rubbing over your back or your belly. And so walking around, moving in different positions in the bed. There's all sorts of things that you can try. And like I mentioned before, we have all sorts of different assistive devices that you can use to help you be more comfortable during that time. If you decide that you want some help with pain, we have 3 different things. One is nitrous. Nitrous is a gas that's inhaled through a mask. We have pumps that we can bring right in the room. Mom places it over their nose and mouth and breathes in, and basically, kind of like at the dentist's office for procedure, you drift off to sleep. But as soon as the mask falls away, then you wake up. So it's kind of funny, but some people really like it just to take the edge off the pain of the contractions. And even with kind of breathing with a contraction, you might breathe the gas and then in between contractions, kind of take it away and let it wear off. So some people really like that. Stadol is an alternative. That's an IV medication. It is a narcotic medication. It has a half-life of about 1 to 2 hours, so we can repeat the dose up to 4 times, and it might take care of things for an hour or 2 and then start to wear off, and you may decide to get a second dose. Stadol does affect your thinking a little bit. It makes you feel a little more relaxed and not care quite so much that you're having contractions. You still feel them, but they might not be quite as painful. And so that's a nice option for some people to use in labor. An epidural is by far the most common choice. About 85% of people end up choosing an epidural at some point in your labor, largely because labor is painful and it lasts a long time. So I think it's a good idea just to go in with an open mind about what your options are so that you feel positive about your experience. There are some people who have birth plans that they've created where they state that they don't want an epidural, but end up making that choice. And my recommendation is just go in with an open mind so that you feel positive about your experience no matter what happens. An epidural is done with an anesthesiologist, and so we have one of the doctors, an anesthesiologist, that comes in the room. There's at least 1 person, if not 2, for our busy labor and delivery unit here at Spectrum Health, to do epidurals and to do obstetrical anesthesia for cesarean sections. So there's an anesthesia nurse that comes in to take your history and talk to you about risks and benefits associated with the epidural. And then the anesthesiologist comes and introduces themselves. If you desire an epidural, you do it right in your room. You sit at the side of the bed, and they place a small, tiny catheter, kind of like an IV, between your vertebrae and your back, in your low back, and that infuses a combination of pain medicine and numbing medicine through your back that's attached to a pump. That way, they can continue to give you medication as long as your labor lasts. If your labor lasts an hour or 24 hours, you can use the epidural for that whole time. Once you have the epidural in place, you really shouldn't feel much pain. You might feel still a little bit of pressure or discomfort, and sometimes the pressure as the head is delivering is still present, but to a much less degree. And a lot of times you can sleep after that, which is nice if you've been in labor for a long time. The epidural, like I said, is taped to your back. It stays in place. It's attached to the pump. You'll have a little push button that you can push that's programmed, so you can't give yourself too much, but if you feel like, oh, I'm getting a little more uncomfortable, you push the button, it gives you a little extra dose, or the anesthesiologist or anesthesia nurse can come in and adjust it if needed. A lot of times it really reduces or takes away completely the pain associated with labor, and some people really like that. Epidurals stay in until you're completely done with your delivery, your placenta is delivered, and if you need any stitches afterwards, then it's still in place for those so that you're comfortable if you need some stitches, if you have any tearing that happens. So epidurals are very safe. We do give you a bolus of IV fluids, and this is to reduce the risk of dropping your blood pressure. Because it dilates your veins, your blood pressure can drop, and sometimes that just makes you feel bad, or sometimes it affects blood flow to the baby and the baby's heart will drop. The heartbeat will go down. And so we give you an extra liter of fluids to help you in that case. If you have a tear after your vaginal delivery that needs repair, we usually do that right in the room and in layers and whatever is needed. It sounds horrible, but it's pretty common, and we do not routinely cut episiotomies, but having some kind of a tear is not unusual, especially with your first baby. And so if we need to, we'll address that right there and make sure that it's fixed and you're good as new. And we'll talk to you about care afterwards to make sure that you have a spray bottle to rinse off with, and that you have some numbing spray and some pain medicine. You get to take ibuprofen or Motrin after you are delivered, which is so great. So that's a part of your treatment course. Epidurals can be used for C-sections too. So if you need a C-section and you have been in labor, then they can just dose the epidural a little differently so that it gives you surgical levels, and you can use that for your pain management during your surgery. We like to have you awake so you can be there when your baby's born, and your partner can be there with you. If you come in with a scheduled C-section where you don't have an epidural or you don't have an epidural already, then they use a spinal block. Very similar, but they give you the same type of medicines and just inject it in the space around in the spinal canal so that you get numb really quickly from your waist down, and it lasts for a couple of hours for the duration of the surgery. So those are kind of the basics about labor and delivery. Okay, so now you've had your baby. So once you've had your baby, let's talk a little bit about what happens. If you've had a vaginal delivery, we are going to put the baby right on your belly, and we're going to try to have delayed cord clamping. The reason that we try to delay the cord clamping is to let the blood flow from the placenta through the umbilical cord to the baby. We found that it increases babies' hematocrits, which is the amount of red blood cells that they have, and they do a little bit better. Some people have a preference to let it go for longer, like 3 minutes, or to wait till it stops pulsing. If the baby's doing well, then that's fine. Most people are fine letting it go longer. Just let your team know that that's your desire. 1 minute was the determination of experts at Spectrum Health based on the literature of the benefit to the baby, and so that's why we choose to do that. So after that time, we'll clamp and cut the cord. Your significant other is able to do the cutting if they so desire, and the baby then will be placed on your chest for skin-to-skin contact. We know that skin-to-skin increases bonding with mom, helps transitioning, improves breastfeeding success, keeps temperature regulation, and so there's a lot of benefits to skin-to-skin bonding. And we'll do that for the very first hour of life until after that is when we do testing like footprints, weights, and do the initial tests like the vitamin K shot, the hepatitis B vaccine, and the eye ointment for the baby that is regularly recommended. So after that time, on a C-section, we can do the same thing. 1 minute delayed cord clamping, and then we hand the baby over to the baby warmer. If you want to do skin to skin, either mom or your partner, that is fine too. Under most circumstances, we're able to do that. So please just let us know. After about an hour and a half to 2 hours in your room or in the recovery room, then we're gonna allow you to go to your postpartum room. In the postpartum room, you're gonna have a postpartum nurse that's gonna take care of you. And we're gonna do assessments where we're gonna check your belly about every 15 to 30 minutes to make sure that your uterus is nice and firm. This involves a little bit of uncomfortable rubbing. Your uterus goes from this big to about this big, and we can feel this little firm ball right by your belly button. And we wanna make sure that the uterus clamps down so that your vaginal bleeding decreases and you don't have too heavy a bleeding. Looking out for risk of hemorrhage or bleeding after you deliver. I want to just chime in here and say that we have 2 adult visitors in both labor and delivery and the postpartum floor, but like I said before, that might change with COVID status, so check with your healthcare provider or the hospital about that. So this slide is incorrect, but it's a moving target right now. If you have a tear or a laceration down by the opening of the vagina or in the vagina, there are several things we do to help you take care of that. An ice pack is your best friend, and we start giving you ibuprofen and Tylenol right away. I know you haven't been able to have ibuprofen for the whole time you've been pregnant, but it suddenly becomes your best friend. So we give that to you right away, whether it's a C-section or a vaginal delivery, and a nice ice pack for your perineum or for your incision, and that is really a great combination. If you have stitches down below on the perineum, we can give you some numbing spray called Dermaplast that can help. We can also give you some Epifoam if you have a big hemorrhoid, and that's like a spray, foam spray with some steroid in it. So there's a lot of things that we can do. The other thing is you get a spray bottle. It's like a water bottle with a spout on it where you can spray down there after you use the bathroom and then blot dry so you don't have to use uncomfortable wiping. The other thing is for babies will help you if you choose to breastfeed with that early, getting the baby to latch on within the first hour, and then we have a whole section talking about breastfeeding afterwards. If you do not prefer to breastfeed, that's okay. Just let your team know, and we have formula available for you in the hospital. You don't need to bring it. You also don't need to bring your breast pump. We have those things available, and so I think that it's better, especially with COVID-19, that you leave your breast pump and supplies at home and use the hospital ones. We have everything available for you, and we're going to do everything to get the baby started, to latch on and give you the support that you need. So that is postpartum. In your room, there's a lot of education that's going to happen. Your pediatrician will come the next day, your obstetrician will come the next day, the lactation consultant can come. We'll talk to you about all the things that you need to know before you go home. You can answer all your questions. There are videos that you can watch on the hospital monitor about car seat safety, infant CPR, and there's lots of resources for you. We're not going to leave you going home feeling scared. So that is all ready for you. Let's see, baby friendly. Just a touch base on baby friendly. I know that Kelly is going to talk in her segment on breastfeeding a little bit. The hospital is baby friendly, and that is a World Health Organization and UNICEF designation given to hospitals who have met a series of criteria to get this designation. What that means is for women who state that they want to breastfeed, we have met the criteria to say that we are being the most supportive that we can be. I don't think baby friendly is 100% perfect, but what it means is that we are going to try to limit pacifier use, keep the baby in the room with you as much as possible, minimize the use of formula and nipples early on, and try to give you the education that you need to have success with breastfeeding. So that's the basic about baby friendly hospital initiative. Skin to skin is an important part of that. There's a lot of other steps involved, but that if you hear that term and you see that advertising, that's what baby friendly means. And Kelly is going to talk to you a little bit more about breastfeeding.
Hi, I'm Kelly Emery, and I am a lactation consultant and nurse and owner of Baby Beloved. I've been working with moms for about 25 years now, and I just wanted to talk to you a little bit about breastfeeding in the early days. Breastfeeding, if you haven't figured that out yet already, can be a very loaded and confusing topic. Lots of information out there on the internet, and not to mention like from your maybe horror stories from your sister-in-law, or maybe some good stories floating out there too. But it can be a big mix of like what's normal and what's not normal. Why does breastfeeding work sometimes, and why does it not work other times? So the first thing I want to talk about is taking a breastfeeding class. This will just be a short little snippet, but there are longer, like I teach a 3-hour breastfeeding class that goes way in depth about most of these topics. So I highly recommend taking a breastfeeding class. It is if it's something that you've never done before, it behooves you to get some information about what's normal, what's not normal, how your breasts work, how your babies work. You know, when we went through middle school health ed class, we just skipped right over our breasts. We talked about our periods and whatnot, but we really didn't talk much about our breasts. But they're amazing things, and there's lots going on around your breasts right now while you're pregnant, and even more so, more to come once your baby comes. So it's a good idea to get educated about your body and about babies and breastfeeding and what that's all about. And I highly recommend bringing your support person. Any kind of partner you have, a dad. If your support person is going to be your mom, bring your mom. Just like bringing a second set of ears to listen to all this is highly recommended. When we look at the data, and we do data, lactation people do data and research on this sort of thing, and we look at what makes breastfeeding work for some people and not work for others. Time and time again, we find that it's not the influence of the lactation consultant, it's not the pediatrician or the OB. The number one factor whether breastfeeding works or not is the dad and the partner, and whether they're on board with it, because he's going to be with you at 2 a.m. not me. So he's going to be someone who knows what to say to get you through, how to advocate for you, how to help you out in the ways that you need helping out. So if the dad or any kind of support person can come along, that is, again, highly recommended. Breastfeeding, going through the classes is the first part of it, but really it's going to be on-the-job training. So it's when you actually have the baby in your arms is when the rubber hits the road, and you're going to understand more about what breastfeeding is about, and that's completely normal. But it's a stepwise process. So just like riding a bike, if you took a class, if you've never seen anybody ride a bike before, but you took a class and you read a huge book on how to ride a bike, that's not going to be as helpful as you watching someone ride a bike. So you watch your older sister or brother ride the bike, and you kind of get a feel for where they put their hands and their feet and what they do and how fast they go. And then when it's your turn to get on the bike, you have a better understanding of what it's supposed to look like. You'll fall off a few times and you'll get back on the bike, and then you'll fall off a few times. You may have some training wheels behind you and maybe your dad holding the back until you feel comfortable to just go out on your own. But it is a process. It's a learning process. So the same goes with breastfeeding. So the breastfeeding class is the first part of kind of learning. And then also, if you know anybody for whom breastfeeding is working and working well, if you can get with them and kind of just watch them breastfeed. And just the more you watch it and you see it and ask your questions, the better it's going to implant in your brain as well. And you have the benefit of YouTube nowadays, where you can, without asking anybody, you can just go on there and there's tons of breastfeeding videos. So that's something that's in your favor as well. So you can kind of see what it's supposed to look like and just the different ways that women do it. So that's something that's free to do, and I highly recommend doing that as well. All right, so let's talk about the first couple days when you have your baby. Actually, back up a little bit even before that. You are making milk. If you've made it past the 16th week of pregnancy, you already have the first meal made. So it's called colostrum, and it's in there, and it's thick, and it's yellow, and it's very small amounts. But it's just waiting in there, kind of swirling, waiting for your baby to be born. So you don't have to think about it. You don't have to look on any recipe book, anything like that. Just, it's already made for you. And it's just because we're mammals, that's what we do. We make milk. So you don't, even if you're going to formula feed, you're making your first meal is already made anyway. So just, that's how that happens. Colostrum in small amounts, like I said, and even in the last parts of your pregnancy, you may even leak a little bit, and you'll notice on your bra that, oh my gosh, there's some yellow seepage on my bra, or my bra is wet. That's completely normal. It just means your body's making a lot of milk, and it's just kind of that colostrum, and it's just kind of seeping out. So that's not a big deal. You can wear some nursing pads if you want to. But it's yellow because it's really high in beta carotene, which is the same sort. It's a very strong antioxidant. It's what you find in like carrots and that sort of thing that gives it that yellowish orange color. A couple days later, maybe a week or so later, it's going to turn into like a more whitish color that you might think of when you think of milk. But the normal first milk that comes out is going to be yellow, so that's completely normal. And some women leak and some don't, so don't read too much into that. If you're not leaking, it doesn't mean you're not making milk. It just means you get to save a lot of money on nursing pads, so that's okay. So when your baby comes out and your baby's first born, we're gonna try our best to do this. It's called like the golden hour, or that first hour where we put the baby skin to skin with you. As long as mom's healthy and baby's healthy, and the nurses and doctors will do all of their assessments. They'll do a quick check to make sure everybody's healthy, and then they're just gonna let the baby stay on you until that first feeding occurs. So you're going to hold the baby. They're going to dry it off a little bit. They're going to put a blanket over both of you to keep your baby warm next to you, and you're just going to lay there and you're going to stare at your beautiful baby, and you're just going to kind of take in everything that just happened and celebrate the new moment. But sometime in that first hour, when you're laying back and you're holding the baby on you like that, your baby's going to start something called the breast crawl, and it is the most amazing thing to see. Like it's my favorite part of my job, if I get to witness it at all. So it's something where the baby is on you, and after they're kind of gobsmacked, like, oh my gosh, what just happened? And then after a while, It could be 40 minutes, could be 30 minutes, could be 45 minutes, whatever. All babies will start doing this, displaying these different reflexes that help them crawl to the breast. They're born with over 20 reflexes that help them crawl to the breast. You don't have to really help them too much get to the breast. They're already capable little beings even from the get-go. And if you think of any other mammal on the planet, a dog, a cat, a little piglet, the mother dog, cat, and piglet don't latch their little newborns. Those little newborns have to crawl and wiggle and find their way, even if they're they can't see. They go by sight and they go by smell and they go by their instincts to find the teat and latch on. And we're finding when we give our little smart babies the opportunity to do that, they can do that too. And it's the coolest thing to watch. Now, if for whatever reason you have to have medical interventions or something is going wrong, that they have to take care of you or the baby afterward, and then you guys get to do skin to skin, that's okay. These instincts are in place for a long time, so you can reproduce that even back in your postpartum room or when you get home. So it's not something that's like a one opportunity that you get to do this breast crawl. Your baby will be able to do it over and over again, even when you get home. So hopefully, though, our goal is to get that baby on you, skin to skin with you, and we don't do any of our major assessments. We don't take the baby away until after that first feeding is done. And the reason for that is when your baby comes out, its gut is sterile. Its mouth, its throat, its esophagus, everything is sterile. It's only been swallowing your amniotic fluid, and that's it. So when it comes out, we don't want to take it away and like populate it with all of our nurse and hospital germs before you've had a chance to have your baby on your skin and your baby gets your flora, your microbiome in on your skin gets into your baby's gut, which is what we want, which is a good thing. Another reason is the colostrum. When the baby takes the colostrum, as remember I said it's very thick, and so it's a small amount, but it's very thick. So when the baby takes it in, it goes down the throat and the esophagus, and it's sticky, so it sticks to the inside of your baby's esophagus and throat. And what that does is it creates a barrier. So like say your Aunt Mildred comes in and starts coughing all over your baby may take those viruses or bacteria or anything in, but because of that colostrum barrier, it's going to be a lot harder to get into your baby's bloodstream to cause any problems. So the colostrum is a feeding-ish, it is a good feeding, but we look at it more like a medicine and a barrier more than anything else. And because of this, it's really, I highly recommend, again, even if you don't want to breastfeed, like breastfeeding is not for me at all, that I'm not even interested in doing that. Even if you can just nurse that one time right after delivery so the baby gets your colostrum, that would be a huge gift to give to your baby. And who knows, maybe you'll like it, maybe you won't, but at least your baby you'd have tried it, and getting baby that colostrum would be a super wonderful thing to give to your baby. So the baby will first, back to the breast crawl, and I go to the website, go to the YouTube actually, and type in breast crawl or biological nursing. There's lots of things for it, but breast crawl is probably the biggest hit that you'll get to watch a baby actually crawl to the breast. So it's very fun to see. So what the babies all do, they all do it in the same row, same order, so that we know that it's kind of hardwired into human babies, because your baby didn't take a breastfeeding class, so they didn't really learn how to do this. So we assume that they must be hardwired to do it. So they use their little stepping reflex to kind of scoot up and squirm around and find you and find your nipple. And they use their little hands to plant on your body, and then they start kind of sticking their tongue out and kind of sucking on their fist, and then they start kind of bobbing their heads and kind of flipping their body and twisting their body to travel. They choose the left or the right breast, and then they go for it. And sometimes it's just a wiggle, and sometimes they just throw their body over there. So your job is just to lean back and have the baby lean back on you, as belly to belly with you on its belly, with its head kind of tilted back, and it uses its arms to get to you. And you just put your arm up and help however you feel naturally to do so. But try not to overthink it. Just go with your gut instinct about it and follow your baby's lead. And the nurses are there to help you as well, to help get in a comfortable position. They might put a pillow underneath your elbow, who knows, whatever you need at that moment. And then the baby just like goes over there and they open their mouth and then they latch on. So it's very little that you have to do. And it is a really cool thing to try if you're willing. So after the first feed, so after we know that the baby's got the colostrum and they've gotten the first feed and they're so happy and all that's done, then the assessment begins and the make sure the baby's okay and you guys fall in love even deeper with your baby, if that's possible. And then, and then from there, while you're in the hospital, you're just gonna do lots of skin to skin like that. And if the baby starts kind of bopping over, you just follow their gut or follow their lead again and just kind of keep doing that. Now, if you're getting sore, if you're having troubles, definitely ask for the nurses or the lactation consultants in the hospital to help you with different positions or ways that you can tweak it to get comfortable. But that's a lovely one. Just the laid back nursing, it's called too, is a lovely one to start with too, because your bottom may not feel so good right after delivery. So leaning back, doing a little bit more sacral sitting, is a nice way to go right after delivery. And in the forever actually is one of my favorite positions. So in the first days, your baby's belly is very tiny. So here's a slide that shows you in the first couple days how big, how little, and then how big your baby's stomach gets. And you'll see it's very small because you have a very small amount of colostrum. A couple teaspoons here or there is a big enough feeding in the beginning. And every day the baby's stomach will stretch a little bit more, and then they will need more. And that's around day 3, 4, 5 is when your milk supply increases. So that colostrum, more water is added to it, and you just start getting more volume. And just as Mother Nature would have it, as the baby needs more, your body will start making more. So how you ensure a good milk supply and for this milk to come in nice and fast for the baby is lots of nursing in the first couple days. So anytime the baby is like sucking on their fist and kind of looking at you and sticking their tongue out, doing any kind of cue that they want to eat, it's go for it. It's like open buffet for the baby right now, like open bar, anything, anytime. So you're just going to do lots of little practice times. They can be small feedings, they can be longer feedings, whatever it is, it's okay. Every single time it's going to signal your body to bring in the milk, bring in more milk, bring in more milk. And the baby gets a little bit of calories all throughout the day. So that's all good. Now the only time that this would not work is if your baby's premature or sometimes if you have diabetes, they may be checking the blood glucose level, or if there's some kind of medical issue going on, the nurses and doctors will guide you whether the baby needs more. But if everything's fine and everyone's healthy, the baby just lives off the colostrum until your other milk comes in, your more transitional milk comes in. So just, open buffet. You just nurse whenever your baby asks for it. I would recommend if the baby's going longer than 3 hours though, between feedings, I would unwrap them and just kind of talk to them, give them a little massage and put them skin to skin with you and at least try the breast. Sometimes it works, sometimes it doesn't. But if the baby starts going too long between feedings, just get your nurse to help. We have very cold hands and it usually wakes them up pretty effectively. They don't like us. So so do that in the first couple days. And excuse me. What they're going to do, because there is no gauge on the breast, so it is a bit of a leap of faith. So you're going to be checking the wet and dirty diapers to see how much the baby's getting. So they will give you a chart, and you're going to be reassured by, oh my gosh, all these diapers, whatever goes in has to come out. So that's something that's very reassuring for you when you see all the diapers. And also, conversely, if there's not enough diapers, that's when you would call the doctor or ask your nurse or get some extra help to see if what's going on. So the nurses will all instruct you on that. So nothing you have to think about right now. They will guide you through each day of that. I would recommend, if you haven't already, to get your pump at a time if you can. The pump is something that all insurances, unless you're a grandfather plan, it should be covered by your insurance. Some insurances let you get the pump ahead of time, and some make you wait for when the baby's born. There will be a link to my website. There's a great Aeroflow is the biggest supplier of breast pumps, and so you can click on that, put in your information, and they'll send you an email about what your benefits are, what pumps you're eligible for, and all these different things, and they just like boom, they mail it right to your front door. So it's very slick. But every insurance is different, so you'll put in your insurance, and they'll guide you on what you can and can't get, and when you can get it and when you can't. But if you can get it ahead of time, it's kind of cool to bring it to the hospital with you, or at least keep it in your car, so in case you go into labor and you forget about it. Because if they have time, the nurses and lactation consultants, especially the lactation, they can fit you for the pump and show you how to use it. There's the things that the breast shields, they're called, that actually go on your breast. They come in lots of different sizes. So having a lactation consultant actually watch you pump and fit you for the right size is very valuable. So if you can bring your pump to the hospital, please do that. And lastly, just know that breastfeeding requires a lot of room for awkwardness and vulnerability and grace, especially grace afforded to yourself. It's easy to afford it to the little baby because they're so innocent, but giving yourself a lot of grace is something that is really needed, especially in the first couple of weeks of breastfeeding. Especially if you're someone who is kind of hard on yourself when things don't work out in life. So sometimes in the beginning, breastfeeding doesn't automatically work out in the beginning. Doesn't mean that it won't later. But if there's a few stumbling blocks in the beginning and you need some training wheels in the beginning, just know that that's completely normal. Most women do need a little help in the beginning. It's a social sport, it's a team sport. So it doesn't mean that you're a bad mom if breastfeeding is not working out. It just means that you need your community, and you need your support system around you, and that's when to pick up the phone, or have the dad or partner pick up the phone and get some help. It can be a support group. It's like the Fight Club in Grand Rapids every day of the week, except for during this quarantine, of course. But usually, every day of the week there's a support group going on. Between all the hospitals, and those are free, and they're just a godsend to be able to see other moms and get some questions answered. If you want a more private setting, there's lactation in the hospitals, and then also outside. People that do home visits, such as me, will come right to your home if you want a more private setting. I'm set up for telemedicine. It's not the same as actually being person to person, but it's better than nothing during this quarantine time. So there's telemedicine options out there. Your pediatrician, your doctor, anybody, just reach out for help is the main thing, so they can get you hooked up to people. I'm not saying that breastfeeding isn't supposed to hurt a little bit. There's usually a little discomfort that comes with it in the beginning, but if you're cracked and bleeding and in tons of pain, like you're ready to throw in the towel, it's definitely time to pick up the phone or get on the internet or whatever, and get some real hands-on qualified help. Someone who does this for a living, someone who really knows what you're going through and has solutions to help you heal and to get over this hump, so you can get to reach your breastfeeding goal. And just know that it can take a couple weeks to feel confident and competent in this. And again, that's super normal. So know the normals and give yourself a lot of grace. Time to be vulnerable, time to fall down, skin your knees a little bit, and then get right back up on that bike. And please do not hesitate to call me or email me if you need help. The links will be below to my website, and my phone number is on there, and I am available just about all the time. So good luck to you, and have a wonderful birth, and I hope to meet your beautiful baby someday.
Hi, my name is Craig DeWitt. I am a licensed psychologist at Psychology Associates of Grand Rapids. We have an office on Cascade Road, but we also, for the last 12 years since the Women's Health Center opened, have an office on the 3rd floor, and have had a nice working relationship with the doctors and nurses on the 4th floor. One of the areas of specialization for us is dealing with postpartum mood disorders. And that's why I'm here tonight. Just want to talk a little bit about that, what that is, how to treat it, how to deal with it, and going forward. And so one of the things we know about going through pregnancy, there are changes. Of course, there's change to your body. And so you're going through this, you notice this change, it's going to have, especially the third trimester, may have difficulty sleeping more difficult. You may feel better in general, have more energy, but there are some of those bodily changes that make it worse to sleep and things like that, and maybe just move around. We also know there's some hormonal changes, both now, but particularly after when the baby's born. And so with those hormonal changes, there can be some shift in terms of how you deal with varying emotions like depression, anxiety, stress, those kind of things. Another change can take place in terms of relationship. And so you have a significant other or spouse, something does change in that both of you are not getting sleep. There is some stress on both your parts. Maybe your response or reaction to one another changes. And so there can be some of that tension that does exist at times. There can be a change in finances. We all know babies cost money. My kids, when they started having babies, all the contraptions and all the stuff that they got to purchase, and fill the back of their car with all this stuff, it costs money, and plus all the diapers or whatever you're going to use. There's also change in career, and I realize that some of you will be going back to work, and it's a difficult thing to know, but I'm not sure how I'm going to deal with that change. And so as a result, there can be added stress about that. Also, how do I function with less sleep and going back to work? Those kind of things. But also, for some who may stop working or go part-time, there's a shift there too, thinking, maybe I'm missing my job. Maybe I'm missing some of the people I worked with. That could make more stress for you. And then finally, just lifestyle. I mean, we all know that once you have a baby, things do change. It's wonderful, but there's also times where, you don't have the spontaneity. You just can't go out and do things with friends. You're maybe closer to home sometimes. And because of that, I mean, I guess people deal with that in different ways, but we know that's a stressful thing. And so those changes are stressful. They can lead to more depression and anxiety, and we want you to be aware of that. Now, we all know with the baby blues, or at least we've heard about it, in that about 50% of women will experience the baby blues. And for the first couple weeks after the baby's born, you may feel a little bit down, tired, because you're not sleeping most likely, but just kind of down and not feeling yourself. And that does go away. But for the women that does not go away, for 15 to 20% of women will experience a postpartum mood disorder. And that's something that goes on for an extended period of time into a month or 2 months, and even beyond that, up to a year. And so we want you to be aware of that and recognize the symptoms that come up. Now, we kind of know, and we've heard about depressions of depressive symptoms or anxiety symptoms, and so that feeling down, feeling worthless, no motivation, just really lethargic, angry, upset easily, those kind of things, worrying about stuff that you normally wouldn't worry about or be concerned about. And so we're trying to change, let you look at those things and say, if they're not going away and there's no way of resolving those feelings, that you're most likely going through a postpartum mood disorder. And so we want you to be aware of that and realize that you're not doing anything wrong. It's nothing you've not told yourself to just buck up and just deal with it, or that I can just put on a happy face. That this is something that you cannot control. And so we want you to be aware of that, so that you can, first of all, be gentle with yourself, be aware that I need help, and that there are people and resources out there to help. Now, the first order of help is the significant other and husbands. You guys, part of it is that we want you to be aware of these symptoms, have some sensitivity to the fact that the mom cannot do anything or change how this feels. And so, guys, read some articles, read some books. Websites are out there. Postpartum Dads is one of them that I use a lot of times and refer to. It's a great resource. It kind of tells you, okay, these are the ways in which the mom may start to feel and how they may start to act. And what can be your response to them. I love it when they have on there, things to do and not to do for the mom. Things to say and not to say. And so I encourage you to, really pay attention to that. And for yourself, get some support from some guys too who may have had a wife who has gone through this. Talk about some things that you could do to be of help. Do things for your wife. Give her time to rest. Give her a break from things. Whatever she asks for, you try to respond to that the best way you can. It's also, I think, important to receive help from friends, family, those kind of things. So if you need help, ask them. And be very specific and almost be almost selfish for yourself, because this is for you and your baby. I remember my wife, when we first had our first child, one of the things that we did, we lived in Baltimore at the time, and so my parents drove up, and they were going to help us after the baby. Helping us meant my mom would sit on the couch holding the baby. My wife would maybe get a shower or take a nap, but a lot of times doing housework around the apartment. And so that did not help. And we learned after that how to set some limits and boundaries on who, first of all, who comes over and visits, but more importantly, what do we need for them? And so be guarded for yourself. Take time and think through this. What do I need for me? One of the things we want to be aware of too, there are some factors that may make you more prone to postpartum mood disorder. One is a family member who has gone through that, because we know there's a genetic component sometimes. Maybe you've had a very severe PMS in the past. Maybe there's been a previous trauma in your life. Maybe there's a conflict or so between yourself with a spouse or with family members. Those kind of things. So there's events there that can create more stress. And so just be aware that that may make you a little more prone to that. So what do we do about this? And first of all and foremost is be honest with yourself, and especially be honest with others. In the packet you'll see, and you've probably done this already, but the Edinburgh is a test that you take. And if you begin to show more symptoms and signs of depression and anxiety, it comes up in the test. And the doctors and nurses are monitoring that, but I encourage people to take it after the baby's born and to look at those kind of things and see how you can address those issues. So besides being open and honest with yourself and others and let them in, do some self-care for yourself. Know what you need, ask for it, sometimes demand it if you really know what that is. The doctors and nurses, if they see this, they will likely make recommendation of possibly medication. If you've been on medication in the past for depression and anxiety, maybe that's something that may be helpful in this situation. And in fact, maybe you're taking them already and just in preparation for this. But then also counseling, and that's where we come into play, and other therapists, if you have a therapist, really utilize them for some problem-solving skills, things that they can help you with, and also how to communicate more effectively. The other thing, and talked about support, there's a great organization in town called Moms Bloom, and it's in your folder, I think. But Moms Bloom is a group of women that come alongside women who are struggling. It's all free. You contact them, they will set you up with someone who will kind of walk alongside you and be there for you. And it's a wonderful resource, and I really want to encourage people to take advantage of that to the degree they can. And then finally, in real severe cases, it's dealing with if it's real severe, using something like the Pine Rest Mother-Baby program. I've had so many women that I've talked to and men whose wives have gone through the program and can't say enough about it. It's just a wonderful program, and they receive so much out of it, including support, encouragement, relationships, everything like that. And so I really encourage people to take advantage if they can. So that being said, I hope you take away from this, first of all, don't feel shame, don't feel guilt, don't feel bad like you're doing something wrong if this happens to you. It happens to a lot of women. And seek out support. They have a support group here at the doctor's office. If you're feeling this way, take advantage of it. It's a wonderful place to be. You talk about self-care, you find people that can really understand you, and you can talk freely. So take advantage of that. Be open with the people around you. Don't suffer in silence. Don't put on a happy face when you're feeling differently. That only makes it worse sometimes. So I really want to encourage that transparency and openness as much as possible. So I'll leave you with that. I hope the rest of your pregnancy goes well, that as a family you can really enjoy the time together. But I know that some may struggle, and please take advantage of whatever resources you have. Thanks a lot.
Hi, I'm Dr. Drew Stransky with Rockford Pediatrics, and I've been asked to talk to you all about what to expect during your hospital course and also some tips for when you go home. Our goal is to help you raise and produce successful and productive children. Okay, wait a second. All we're going to do is try to get you through the first couple weeks here. All right, so first off, how are we going to choose a pediatric provider and office? There's different things that are important to different people, and I'm just going to brainstorm with you some things to think about. First off, let's tell you this. You're going to see this person a lot. In the first year of life, you see your pediatrician given 7 times for wellness exams. If you talk about the 2-week, 2-month, 4-month, 6-month, 9-month, 12-month, plus the initial checkup right after discharge from the hospital, that's 7 visits. And that doesn't include any weight checks or potentially sick checks somewhere in that first year of life. So it's something that you want to make sure that you feel comfortable with the office that you're going to be seeing. So things that are important to some people, location. Some people are requesting that their office be within a couple miles from their house. Some people don't mind driving a greater distance. It really depends on your needs. What are their hours? What are their availability? Are you able to talk to the provider? Are you able to talk to their staff? How do they handle after-hours calls? And some groups will take their own calls, such as our office. Some groups will have a nurse triage line, and some groups charge you for those phone calls after hours. Those are all good questions to ask. Do they have any walk-in hours? What is their availability on weekends and after hours? What are their reviews like? I always recommend that families check out their Facebook or Google reviews, because you can hear a lot of information about what other patients have said about that office and their experiences. And then finally, some offices will do what's called get acquainted appointments. We do this probably a couple times a week, where we'll send new expecting families into the office. We sit down and talk to them, answer their questions, and allow them to tour the office and meet the staff and make sure that it's a good, comfortable fit. And that might be a choice that you want prior to making that decision. All right, so now let's shift gears to what to expect in the hospital. So you've had your baby, and your baby's going to be seen by a pediatric hospitalist. And a hospitalist is a pediatrician that's trained just like I am, but they only do outpatient work. So their job is strictly in the hospital. So you'll see them for a couple days, and then when you go home, that's when you transition your care over to your regular pediatrician. That's pretty standard for most of the Grand Rapids area. So in the hospital, the pediatric hospitalist will do a good exam on the baby, will help to answer any questions that you have with breastfeeding, may even perform a circumcision if you're having a boy, and generally just make sure that your baby is doing well. Right after birth, a couple typical things that take place. We will use a substance called erythromycin that we put in the baby's eyes to prevent against bad type of bacteria that can cause scarring to the eyes, or in rare cases blindness. By using this antibacterial ointment, it virtually eliminates the risk of that. It's a one-time deal. Vitamin K is a vitamin that's made in the liver, and if you look at the baby as being immature in general, we want to make sure that they have enough vitamin K stores so that they can be able to clot and stop bleeding. So why was that important? Well, babies go through the vaginal canal and have the squeeze, which puts a lot of pressure on the brain, and if there was any kind of microscopic bleeding, you'd want to be able to stop that. And also for those who are having a boy with a circumcision, we would not want to do that if we couldn't stop the bleeding with the circumcision. So really important. Now, after about 6 weeks, that vitamin K stores kick in with the baby, and the need for supplement isn't necessary after that. So that's just a one-time situation as well. Hepatitis B is the only immunization that's given in the hospital. Hep B is a 3-part series, and we finish that in the office after you guys are discharged. Why do we give it in the hospital setting? It's because they test all moms early in your pregnancy to make sure that you're Hep B negative, but heaven forbid you contracted Hep B somewhere later in your pregnancy and didn't know it. By giving that shot, it almost eliminates the risk of the child getting hepatitis B. So instead of having to retest mom over and over again, we just blanketly give it at that stage and then finish the series as an outpatient. They'll do hearing screens in the hospital. It's a little machine that they'll take the baby to test to make sure that they're hearing properly. Some of the take-home points with that is it's very common for babies to fail that initially. It may be just one ear, it may be both ears. If that happens, don't worry. They'll repeat the test prior to discharge. I've had parents that come home where they still failed, and we send them to audiology and they end up passing. Every once in a while, we'll get a child that has some congenital hearing loss, and it's important to recognize early on because we can do something about that, whether it's hearing aids or extra therapy, so that it doesn't affect their speech as they're growing. We'll also do what's called a newborn screen. That's where they do a little heel pick on the bottom of the foot, and they blot it on a card, and that card is sent to the state, and it looks at a battery of tests that are important for the baby's development. Most of the time, this test comes back perfectly normal, but there are certain conditions that they look for. A lot of these you've never heard of before, but some that you may have would be cystic fibrosis, sickle cell anemia, hypothyroidism, and those are all things that we can correct or get to the proper attention to if the baby tests positive for it and can change their outcome and change their overall life. That usually comes back at about 2 weeks too, by the way. Blood sugar screens, they'll do that, especially if your baby is high risk. And the high risk category would be a child who's low for gestational weight, high for gestational age, weight, or if you're a parent who is a pregnancy diabetic. All of those children have a higher risk of having low blood sugars, and so they may do some checks and make sure that they're normal. If they're too low, it's very easy. We feed the baby. We can give them sugar water, we can give them formula or breast milk if it's available to get the blood sugar up, and then eventually that seems to equalize, and then it becomes a non-issue after that. Jaundice checks are another thing that will be done in the hospital. Jaundice, for those that don't know, are yellowness of the skin, and that is a normal physiologic process that takes place with babies as they are developing the first couple days of life. Partially, it is because mom's breast milk has not come in, and the way we clear our jaundice is through urine and stool. So as the breast milk comes in and mom's feeding is going better, then the baby starts to clear that. Jaundice is only dangerous in high values, and we never let it get to that level. So in the hospital, do what's called a transcutaneous bilirubin check, which is a meter that they put on the baby's forehead, and it gives a reading. And if it's in a normal range, we don't go any further than that. If it's elevated, they'll do a heel stick like we talked about with the newborn screen, and they'll verify it through the lab that it's actually elevated. Well, what happens if a baby has too high of a jaundice reading? Well, there's things we can do. We can use phototherapy, which helps drive down the bilirubin to make sure that it's not in a dangerously high level. We can send babies home with what's called a billy blanket, which is a blanket of lights that helps to prevent the jaundice level getting too high as well. Sometimes they'll have babies get a bilirubin check as an outpatient. Those are all acceptable things. So jaundice peaks at about 2 to 4 days, and in the hospital, if you go home on day 2, they'll have a bilirubin check done, and that's why we see you 2 days after discharge typically, to check your baby's weight and also make sure that they have not, the baby has not developed excessive jaundice. So we kind of eyeball the kids in the office, and if it is elevated or they look excessively jaundiced, then we send them for another outpatient check. Circumcision. Parents will ask me, should I get it done? And the real answer is it's your decision. It's a personal, cultural decision. The benefits of the circumcision is it can decrease the risk of urinary tract infections slightly. It can also help with cleanliness, and the foreskin of the penis has been shown to harbor the HIV virus. So those are 3 reasons, positives for having a circumcision. Not enough, though, for us to say universally, yep, every boy needs to have that done. I will say about 80% of our office has circumcision. You won't make a bad decision. It is your choice on that. Breastfeeding. I know earlier in the lecture, the OB nurses have talked to you in detail about breastfeeding. I want to give you just some of my take-home points. When you're in the hospital, really utilize the OB nurses and the lactation consultants. They have years of experience and a wealth of knowledge to help you through those first couple rough days. Breastfeeding is truly an art. There's a spectrum. On one side, there's those moms who just do fantastic. The baby latches well, they produce plenty of milk, and everything's great. And there's the other extreme where it's a struggle, where moms just aren't producing enough milk, or their milk hasn't come in yet, or the baby's a terrible nurser, or having a problem with latch, and there's everything in between. We're here to help you, and so when you go home, you are not stuck. I always tell my moms, let me stress about it, and we're not going to let you fail, and I believe that because if we see that baby's losing weight, we'll bring you in every couple days to do a weight check if we need to make sure that your baby's going in the right direction. Our office has lactation that rotates through the office. A lot of other offices around town have that as well. And for those that don't, they should be able to get you in touch with a lactation consultant through the hospital to make sure that your questions are answered. So you're not stuck when you go home. And the first couple weeks, remember, is a learning process where you and the baby are both learning how this works here. Okay, so now let's shift over to the care of the newborn, some issues with that. So vitamin D supplement, that's a vitamin that is essential for bone development. And vitamin D, we get it through 2 sources. We get it through our diet and we get it through the sunlight. Well, the sunlight's the issue, especially in Michigan. It feels like for 4 months in the wintertime it's gray, right? And so by giving vitamin D supplement to the baby, we're able to ensure that they get enough of that vitamin D that they need as they're growing. It's very rare that a child would end up being vitamin D deficient, but by giving these supplemental drops for our nursing moms, it essentially eliminates that risk here. So most of the formulas we'll use are concentrated, so it's like 1 drop a day, and it's very easy to use. The take-home message with this too is you are going to forget a day or 2. This just happens in life. Don't worry about it. This is a preventative thing. We tell our moms, do the best you can. Put it next to you. Put it in an area where you're nursing or a changing table or something that's going to jog your memory that you have to use this on a daily basis. But if you miss a day or 2, it's not the biggest deal in the world. Also, we continue this as long as a mom is breastfeeding. Once you go on to formula or milk, whole milk, whatever that case is, then that's when we would stop those vitamin D drops. Okay, so care for males of the circumcision. Once the circumcision is done in the hospital, it usually takes about 10 minutes or so. And to back up, we use two forms of local anesthesia for this. We will do some lidocaine to numb the base of the penis, and then they'll use some sugar water to keep the babies comfortable. After the circ is done, the head of the penis is going to get kind of red and angry looking, and there's some swelling where it was clamped off. And then after 24 to 48 hours, you're going to see a yellow coating over the head of the penis. All of those things are normal. If I don't tell parents about that yellow coating, you're going to think it's getting infected, and that's not it. It's just strictly part of the healing process. So at the hospital, they'll show you, you'll use some Vaseline and some gauze pads to keep it clean and protected while it's healing. When do you stop that? It's usually 5 to 6 days out, and the telltale signs is when that redness has kind of milded out and that yellow coating is gone. Once those are established, you can stop the Vaseline and care for the penis like normal. Females, they have their own set of issues you have to be aware of. Hormonal changes take place in babies, mom's hormones that are inside of babies. So for young girls, we can see the vaginal labia will get swollen, red, warm. You can get some discharge out of the vaginal region, whether it's mucousy or bloody, and that is normal. It's like having a mini period. So I tell parents that because when you see a little blood in the baby's diaper, you're going to think, what in the world's going on here? And that can be just a normal phenomenon here. Also for boys and girls, it's not uncommon to get like a firm breast bud under their nipple, and that is estrogen changes that take place, and that's something that will go away with time as well. Especially for those little boys, we don't like the dads to worry that their boys are growing breasts. This is just a normal hormonal change, and it will get better. Umbilical cord, it usually falls off at about 2 weeks. All we have you do is keep it dry and clean while we're waiting for it to dry off or to fall off. A little tip also, that cord as it's drying up likes to stick to the normal skin of the abdomen. And so we try to keep it loose so that you can get air that circulates in there, because if not, it starts to break down and you get this really foul smell that takes place. So keeping it clear and clean is really the biggest take-home messages with that. Baths, we will do sponge baths until two things are accomplished. Once the cord has fell off, and for boys, the circumcision's healed, then you can start doing sink, like immersion baths. But in that, prior to that, we'll just do sponge baths. Parents will ask me, how often should I bathe my baby? It's really up to you. We usually say, a couple times a week, every other day. It doesn't have to be a daily occurrence. Babies aren't getting that dirty, but they still will like dribble or drool with breast milk or formula, and it can get stuck in the folds and so forth. So just sponging them off is a good task. Bowel movements, there's a whole rainbow of colors, as I say, that we're going to see. The babies will start off with this black tarry substance called meconium, and then that will gradually pass, and then you go into transitional stools, and the color kind of goes from brown to green to yellow, and then the final product for breastfeeding is yellow and seedy, and that's normal. So parents will ask me, what exactly is it supposed to look like? Well, I don't know why we do this, but we always compare things to food. So the best way to describe breastfed stools is like mustard with seeds. That's exactly what it looks like. And that's normal. And I like to tell folks that as well, because they'll think, oh, my baby's having diarrhea, and it's not diarrhea. It's just normal breastfed stools. Babies are very efficient with processing breast milk, and so it's not uncommon to have little squirts nonstop throughout the day where you feel like, oh my goodness, I just changed this baby's diaper. That's normal. And that will change down the road. At 4 months, you might have a baby that doesn't poop but every 4 to 5 days. That's normal as well. What's most important when it comes to stools is the consistency. We don't like rock hard stools or constipation. Kids that are going and it's soft, that's the most important thing, whether it's daily or whether it's every other day. Early on, it's important that your baby's stooling daily in the first couple days of life, because it's an indication of how your breastfeeding is going. But after that, it's not as much a reflection of that. Sleeping, babies will sleep about 18 hours a day at first. And I always joke, at first you're going to say, does this kid ever wake up? And then after about 2 months, you're going to say, does this kid ever sleep? And this is normal. So a lot of our growth, or most of our growth, is done during sleep. So the babies come out and they have glucose stores on board that they're able to utilize. They are kind of go through, as I call, their newborn coma, and they're growing rapidly and recovering from the delivery process. So sleeping a lot is normal. There's a big difference between babies who eat well and then sleep and then eat well and sleep. That's normal, versus a baby that you can't wake up to feed. That's a problem. If that's the case, you need to talk to your pediatrician. I know earlier in the lecture, the OB nurses also talked about postpartum depression a lot. So I won't go in detail about that, but a couple take-home points. In our office, in most pediatric offices, they'll do what's called an Edinburgh screen. An Edinburgh screen is a postpartum depression test, and it will ask you a series of questions to see how you're doing. If you score positive on that, we'll talk to you about getting help through your primary doctor, or through your obstetrician, or getting counseling, those type of things. The big take-home message I wanted to mention is that there's a big difference to me between postpartum depression and baby blues. I will tell you that I would say 90% of moms have some element of baby blues. And the difference with that is baby blues are just episodic periods where you're just crying or emotional. Postpartum depression is where functionally you just struggle and you're having bad thoughts and so forth. With baby blues, it is temporary, and it has to do with the fact that we have a child that's all-encompassing, we're not getting any sleep, and we have hormones rushing through us. The combination of that makes it very likely that you're going to have some teary-eyed episodes, and that's normal. So the main take-home message is, if that happens, give yourself a break. Things that can be therapeutic. Go out and go for a nice long walk if it's a beautiful day. Utilize your spouse or your family members to help you so that you can get out of the house or you can get some fresh air. That can sometimes make all the difference in the world. Or even if you need to nap during the day, do it. If the baby's sleeping, you get your sleep. The dishes can wait and other things can wait. What's most important is you take care of your own health. So some common newborn issues that we see. Hiccups, very, very common. And a lot of you moms have felt your baby hiccuping inside of you. Well, that continues once the baby's born. And so hiccups can be very pronounced, and they can be very frequent because they're usually established by feeding. So you feed and it triggers it, and then sometimes feeding actually can stop them as well. They're harmless. It's nothing to worry about, and it will get better as the child gets older. Nasal congestion, I always say that this is the norm in the newborn period. There's a variety of reasons why babies can be congested. It can be that they have a cold. It can be that they reflux to some breast milk or formula. It can be environmental exposures, not necessarily allergies, but like pollens and stuff blowing around, or the forced air furnace in the wintertime. The baby's nasal passageway is so tiny, it's really small. And so anything that gets in there is going to make it sound worse than it really is. If your child, though, is struggling to breathe, like with feeding, or is really congested, what do we recommend? We have you use the bulb suction or the nose Frida. And a little tip for you is to block the other nostril when you do it so that you create a vacuum to get as much out as you can. If you just put it in there and suction, if you're not directly up against something, it's going to just suck air out of the other nasal passageway. So a little tip for you there as well. Diaper rashes, very common in the newborn period, partially what we discussed because they're having such frequent stools. And you can be the best parent in the world, but it's so hard to keep up with it sometimes. So as soon as you start to see that your baby's bottom is getting red or raw, that's the time to start using a barrier cream such as a Desitin or a zinc oxide product to help keep it clean and to protect that skin. It's the stools that are acidic and they literally burn the skin. So if we can keep the stools and the diapers clean and use a barrier cream, that's usually all you need to do. Crying, I know it's a shock to most people, but crying is normal in babies. And they're gonna cry a lot. Most of the time it's for a need. It's either they're hungry or they or they have a dirty diaper, or they're sleepy, or there's a variety of reasons for it. What I want to stress though is that especially in the evening, some kids will have just their fussy periods where they just kind of need to let it out for whatever reason. As a parent, what you have to do is reflect on, have I done everything in my care? Have I changed the baby's diaper? Have I fed them? Is there something that's bothering the baby? If the answer to that is no, then it may just be a lot of rocking and calming in the evenings as the baby settles down. On the flip side, if a baby is fussy all day long, all the time, that's not normal. And that's when you need to talk to your pediatrician about that. Blocked tear ducts are another thing that we'll see with babies that are very common. So there's a duct that connects from the eye to the nose, and that's why when you cry, you sniffle. Those are tears pouring into your nose. Well, those ducts get blocked in babies because of the birth process or because they're just so microscopic, and they may have a cold or some swelling and blocks it off, and they'll get tears that stagnate in the eyes, and then the surface bacteria get in there and it goops up. This is a harmless process. It's not a pink eye. So what we have parents do for that is just wipe away the discharge and use your little finger and just go right in the corner here and kind of massage in that area, and it helps to push that down and hopefully break open that duct so that it will drain effectively. It can last a day, a week, months, and then eventually it just goes away, and it's a harmless thing. Last thing to talk about is newborn safety. Car seats. We recommend, obviously, the babies are rear facing in the back seat of the car, hopefully in the middle of the car if it's feasible. Spectrum does a good job of doing car seat checks, and also they offer a class that you can do if you want more information on that. A lot of the local fire departments will do car seat checks as well. The key with the car seat is making sure the base is in there tight and level, and sometimes it means building up that base if your car seat is angled a little bit with either a blanket or a piece of foam to allow it to sit level, and getting in there and putting your knee and your weight on there when you pull the latch system to keep that base in there tight. So those are just some take homes with that. Babies should sleep on their back. We talk about good crib safety, either a crib or a bassinet, what they're wearing, a light blanket, and nothing else in the crib. No stuffed animals, no bumpers, no pillows, any of that stuff. We can try to keep that out of there. The reason we want kids on their back is so that they wouldn't asphyxiate or get stuck into something where they couldn't breathe. And that's why when babies were belly sleepers, the incidence of SIDS, or sudden infant death syndrome, was higher in that age, in that period. And it has plummeted since we've gone to the Back to Sleep campaign. So really important. Other things that can cause SIDS is being around cigarette smoke. And smoking in general has a lot of harmful effects for the baby. In addition to SIDS, it can increase illnesses in general, ear infections, asthma, and so forth. So if you are a smoking parent, we talk about smoking outside your house and not in the car. If you have any family members that smoke, have them just do the same. And then if you can, we try to get you to quit. If you can't, wear a smoking jacket or something that can get the kind of the odor and stuff on that you can remove, so the baby's not inhaling that secondhand smoke. And the final message that I'll leave you with is about a syndrome called shaken baby syndrome. And shaken baby syndrome is where a baby has been rapidly shook and that the brain jostles around in the skull and it tears blood vessels, and it's a devastating condition. I've seen several of these kids years ago when I was a resident, and it's just heartbreaking. You have a perfectly healthy baby who then has lots of neurologic and eye problems after that. This is an avoidable situation, and this take-home message is that babies are frustrating, and they are all-encompassing, as I mentioned, and you can see where parents don't mean to do this, but what happens is they're frustrated and they pick the child up. Why won't this kid stop crying? And that's all it takes. So never let it get to that point. If you feel your emotions are building up or you feel your level of frustration is building, put the child in the crib and walk away. Babies don't get hurt by crying. So utilize your spouses, as we mentioned, utilize your family members, and give yourself a break, because it can be they can be very difficult in that early time period. That concludes my component to this lecture. I hope that is helpful. Good luck to everybody, and have a safe and healthy pregnancy.
Hi everyone, I'm Dr. Rebecca Lax from Grand Rapids Women's Health. Today I'm going to talk to you about car seat safety. It has been found that 4 out of 5 car seats are actually improperly installed. So today I'm going to review some highlights and tips to make sure that your car seat is installed correctly. From the infant stage to 2 years of age, it has been recommended that the child ride in the back seat of the car in a rear-facing position. You can either use an infant carrier, as seen here, or a convertible car seat. Using an infant carrier, you want to make sure that the carrier itself is installed securely within the base. The base is then installed to the seat through the latch system, or using the seat belt, lap belt, if you do not have a base for your car seat carrier. You want to be sure that the infant is securely strapped within the harness belt system. So looking here, the 2 shoulder straps, you want to make sure the level of the shoulders are just below. You want to be sure that the chest clip, which is seen here, is at the level of the armpits or the nipple line. You don't want it any lower. It is also important, especially in the winter months, that we do not dress our infants in multiple layers of clothing. You don't want to put a heavy coat or jacket on your baby and then put them in their car seat. You really just want a single layer of clothing between the car seat straps and your infant. They do make covers that fit securely along the edges of the car seat, which are safe as long as they're outside of the belt harness system. Along the same lines, it's very important not to use any sort of toys or dangling objects from the infant carrier handle. In the event of a car crash, these could become dislodged and act as projectiles. It is also important that other items within your car are securely fastened, such as groceries, bags, or purses. That's it for car seat safety. If you have any questions, please don't hesitate to call us or email us. Thanks.
I want to close by thanking all of you for taking the time to review this video. I hope that it's been helpful. On behalf of all of the doctors and staff at Grand Rapids Women's Health, I want to thank you from the bottom of my heart for trusting us with the care of you and your baby during this pregnancy. Please let us know if there's anything that we can do to give you any reassurance or added information during this very special time in your lives. If there's anything new that comes up with the COVID concerns, please call us. I know that these are unprecedented times and we are all a little bit anxious, but I want to continue to make this just a very special time in your lives, and thanks for trusting us.